Yeah, so what do we think some concerns for weakness could be for a patient? Tiny heart syndrome or microcardia? Okay. Complainers, whiners, poor conditioning, lack of conditioning? Okay. Can weakness also be related to a neurological dysfunction? Yeah. You probably see microcardia more than that. Anyways, my first battalion commander, I think I sat down and we were going over some med pro stuff, and I said there was a lot of microcardia in the battalion, and he looked at me and just started dying laughing. I was like, is that a real thing? And I'm like, I mean, probably, but not in the way you're thinking of it right now. So. All right, let's go over weakness. Some of the things we'll talk about. The gait stuff is hit or miss. I think the videos do more justice for it for me. Just bring this up. MS, unfortunately, I found a couple MSs out there on active duty, plus or minus med board, but you'll see it out in the civilian world. ALS is one we're going to talk about, and then cord disorders toward the end. I think it's pretty interesting because it talks about spinal cord injuries and how do we as a clinician bedside, if someone's coming in on a board and call it, figure out what part of the spinal cord are we concerned about, right? Yes, I agree, you're going to pan scan. Yes, you're probably going to get that, we call it the box of answers. You're going to get that from the CT scanner, but understanding bedside, like why have they loss of motor function, or why can they have sensory but no motor function? That's what we'll get into a little bit later. So. All right, how do you assess weakness? Like you guys were just saying, or I was talking, is it a conditioning issue? Is it a muscle problem? Is it a nerve issue? Or is it a mixture? And that's really the hard thing to figure out. Is it purely neurologic, purely orthopedic, or a combination of both, which is when it gets kind of tricky. So I'd say majority of the time it's unfortunately usually both. All right, weakness. Disease, this is just some anatomy stuff. I've been known to throw kind of easy questions on there, like what is myopathy, right? Just so you guys, I know you guys are paying attention. And I only have 2 tests with y'all, so I got to make some of the questions like first level, right? So a lot of them, like, what does the term hemiplegia mean? All right, so paralysis of half the body, we know that too. But understanding what paralysis is, so we can't feel anything, right? You can't move anything. Hemiplegia versus paraplegia versus quadriplegia, what is that? Do we know? Yeah, 2, 4, 6, 8, right? So half the body, hemiplegia, maybe I have right-sided paralysis versus paraplegia, upper versus quad, all 4. So good, easy money. Easy money. Paresis is less severe weakness or incomplete paralysis. Maybe they just have degradation, they can kind of move a little bit, feel a little bit, but it would be termed paresis or hemiparesis or paraparesis. Stuttering. All right. Things we got to figure out: onset of symptoms, evolution, right? So was it fast, slow, subacute, acute, months, years, days, and then how has it progressed? Episodic, steadily, rapid. So those will kind of be tellers, and you'll snuff that out with OPQRST sample history. So there's nothing really new about that information. All right, identify the distribution with your neuropathy symptoms. Is it isolated, multifocal, proximal distal, along a dermatome? We kind of hit that last class, right? So where is the patient having symptoms? Is it stocking glove distribution? Is it along that T12, T10 dermatome? Does it stop midline? So that's just kind of saying, right, listen to your patient and see what they're complaining about. Hey, my leg or legs are going numb, right? So that tells you mono versus polyneuropathy. And they'll give you a lot of the hits. But by God, sometimes you got to yank it out of them, and that's okay, right? So some patients want to tell you very little. Some patients want to tell you their whole life story. So you guys, and that is the kind of the art part of this job, is figuring out when to intervene and tell them mildly interesting, highly irrelevant in a respectful way. But we need to focus on kind of what you're here for. So, okay. That's always fun. They drone on and on and on. I usually listen to them because I try to be good listener. But anyways. All right. And then again, localizing it to a specific part of what we're talking about in neurology. Is it a brain issue? Is it a cord issue? Is it a nerve issue? Neuromuscular junction? Some of these can be harder to snuff out. I'm not trying to oversimplify it. If someone's having, headache, nuchal rigidity, and blurry double vision with a fever, like I'm not worried about neuropathy in the feet. I'm worried about meningitis or encephalitis, which we talk about later. They come in and they're morbidly obese and have stocking glove distribution of neuropathy. And worried about diabetic peripheral neuropathy. So those type of things. Isolated multifocal, what does that mean? One area versus? Yeah, good. And then proximal or distal, again, this is you guys clipped out of the medical vocab class. Did we make you guys take that?
Yeah.
Wasn't it exciting?
Yeah.
Yeah. So is it closer or to the midline or closer to the body or farther away? So, and again, those can be some of our tips. So if we get all that, we get a good feeling for that. It says there, we're more than halfway there. I'd say you're half. That's halfway. Let's not oversimplify it. You'd be like Dr. House and be like, all that, it'll be curious to eat. But you ate a French fry, so it's probably this potato-driven disease. I don't know. If you can do that, God bless you. You have a great brain. All right, focus physical exam. Look at their muscle appearance, muscle tone, strength testing, reflexes, sensory gait, or sensory testing and gait. Do these look familiar, guys? When did we talk about this? CS2? Like, we don't remember. So your neuro exam, right? So looking at tone, right? Muscle appearance, strength is graded on 1 to 5. Good. What are our reflexes? Good. Okay. Just making sure we're paying attention. Don't forget that stuff because it's not going away. So our muscle tone can be hypertonic. Spasticity is usually going to apply an upper motor neuron lesion, and we'll talk about this in a second, right? Spasticity and rigidity. Hypotonia is usually going to be indicative of a lower motor neuron lesion. So what does a hypotonic patient look like? Well, you can see that baby there. Does that baby appear hypotonic? Yeah, that's like lifeless. It looks like it's dead, which is very scary. That would be the patient that if you came in, based off our last lecture, if you came in and you saw this kid, what would be in your differential? Nodules. Right? You're like, mama's giving him canned veggies. You're like, slam dunk. Like, this is a problem, right? So we don't just sit there and kind of just start stroking our chin and we're like, but what type of canned vegetables, right? We go to work on that. Kiddo needs an airway, needs a vent. Now we can figure out other stuff later. Okay. Would like you to know the difference between an upper and lower motor neuron lesion. Do we feel good about this? If we had been exposed to this before? I don't know. I'm asking because I don't know. No? That's okay. Little refresher? Gotcha. So the difference, upper motor neuron lesions, how it presents, I would like us to know that. And we'll talk about what it is in a second. But presentation is going to be important for us. So spasticity, diffuse weakness, hyperreflexia, positive Babinski, no atrophy until late versus a lower. You're going to get flaccidity, focal weakness, hyporeflexia, negative Babinski, and then wasting of your muscles. Okay? And I'll talk to you guys about that in a second. This is just showing our upper and lower motor neurons. Do we remember what an upper motor neuron looks like? Brain down to the spinal cord, right? And then what does it do from there? Desiccates or talks to a lower motor neuron. Okay? I think we talked about this, didn't we? I could be hallucinating, but I talk about it in my dreams to you guys. I'm just kidding. That would be super weird. So. And let's talk about this in a second. This is just showing you the lower motor neuron lesion. I'll simplify it. I will Bostonian the crap, UMass Amherst the crap out of this for you in a second. So. All right, reflexes. We've talked about the reflex arc, really. We've talked about this interneuron and how this prevents it. So look, so from here out to my muscle, is that upper or lower motor neuron? Lower. So when it hits here and goes up to the brain, that's you guys are already, somebody's already playing this, love it, right? So when I do a reflex and it comes, so is this afferent or efferent? Afferent, exit is E, just remember E, exit. And it comes here, this interneuron is what's causing that reflex, okay? I feel like I've done that before. Maybe I did it with the other sophomores, I don't remember, that's the problem. So what's happening in a motor neuron with an upper motor neuron lesion or disease? So you guys can see here, oversimplification from me to you. Brain down, you can see that's the upper motor neuron from the spinal cord, and then you can see that terminal end or that synapse. And then from there, the synapse goes out to our lower motor neuron. Okay, does that make sense for everybody? That's just what we just said. No new information there. So for our lower motor neuron injuries, for our God damn it, Chris, pay attention. So for our upper motor neuron injuries, all you gotta do is read the slide, man. So I didn't mean to say God's name in vain too. I'm a Catholic boy, that's really not good. So what we have here, if we have loss of a negative stimulus, so if we have loss of a negative stimulus, This thing's sending a message to here, upper to lower, and there's no negative stimulus. What's going to happen? We're not telling it to shut up. It's going on and on. It's like me droning here. You're going to have hyperreflexia, spasticity. You can get diffuse weakness. Why am I going to see weakness after a while? Because you're tired. You're tired, right? You can also have a positive Babinski, and you won't see muscle atrophy till late, okay? Let's make that make sense. So for a lower motor neuron injury, we get our inhibitory stimulus continues normally, but that positive stimulus is gone, and the muscle receives no message from the brain. So if your muscle, so we have overstimulation, not shutting off, now it's just not getting there. It's just not getting here. So this is our problem here. This muscle fiber isn't getting any stimulus whatsoever, or stimuli whatsoever. So what is that going to look like? It says it up there for you guys. But the complete opposite of what we just talked about with an upper motor neuron lesion, our lower motor neuron lesion is going to be the opposite. So flaccidity, focal weakness, negative Babinski's, wasting of muscles, hyporeflexia, and fasciculations. Fasciculations, why? It's not getting any stimuli. It still remembers how to do it a little bit, so it's kind of asking for it, and it's kind of like, hey, I'm here, but no one's talking to me type deal. That's going to be a late finding too. So, does that make sense for everybody as far as upper versus lower motor neuron lesions? Okay. And just the difference of the two? Okay. How does that present with your patients? So types of, we talked about walking our patients being extremely important. So again, if I'm not getting stimulation, let's just simplify it even more. If I have a lower motor neuron lesion in my foot, we know that we're going to see what? What's my leg going to look like? Flaccid, hyper, or hypotonia? Hypotonia. So, and again, you guys can use me, or I can use myself as a real example, because I told you my peroneal nerve was injured. If you listen closely to how I walk now, I have a little bit of a foot drop. I notice it. Orthopedics doesn't notice it. They're like, you're fine. Stop being a bitch. I'm like, it hurts. It hurts. But I have some muscle wasting of my calf, my gastroc, and my soleus from that peroneal nerve, and also my interweb space, my first and second digit, and I can feel my foot drop a little bit. Is that upper or lower motor neuron? Lower. You're on it, Dag. I love it. So this can affect your gait, and that's going to be important. That's why we walk our patients. Okay, that's why we walk our patients. For gait testing, all levels of the neuroaxis contribute to the gait. We talked about this, right? So most gaits are motor in nature. To assess a gait, we walk our patients. Okay, these are the different gaits that our textbook goes over. So hemiperidic, paraperidic, step age waddling, Parkinsonian gait, apraxia, chorioathetotic, cerebellar, ataxia, sensory ataxia, vestibular, astasia, abasia, which sounds like a spell from Harry Potter, but astasia, abasia, right? We'll go over these. For me, seeing it does me more justice, and me walking up and down the aisle isn't fun or cool for you guys. So I got some videos that I think are helpful. Your feedback's always welcome. Fortunately, I can't embed videos into my exam because Canvas will explode. So again, I'll tell you which ones to focus on for the exam. The important part for me, for you guys to understand as students going through here, future clinicians, is walk your damn patients. Walk your damn patients and try to figure out what's going on with them. Practice. Don't be weird about it. If you're out in like Walmart or something, or Target, and you're seeing somebody with a gait issue, try to figure out what's going on. It's actually kind of fun if you're not a creeper about it. You're like, yo, right? See what muscles are involved. See what's going on. You can even do it like the way my foot drops, right? I'm over-exaggerating now, but man, what's going on with my foot, right? So try to see what muscles are involved with the person, how they're walking, and then try to backwards or reverse engineer that thing. And if all else fails, we can get some imaging and see what's going on as well. So, all right, our hemiperidic gait, right? So unilateral weakness and spasticity. So this is going to be caused by brainstem, cerebellar, hemisphere strokes, tumors, and trauma. So what are you going to see? So flexion at the elbows, wrist, and fingers. So again, hemiperidic, half the body. So it's going to be upper and lower, one half. Usually this young lady over here has it on the left side. Extension of the hip, knees, and ankle. Forward swing and spastic leg requires abduction and circumduction. So again, they're going to come out and kind of up, out and up. I know you guys can't see. I told you I wasn't going to do that, and I just did it. You're welcome. We'll watch a video. Let's fly through these and then we'll watch the videos and hopefully that makes sense. So. All right, paraplegic or diplegic gait or scissor gait, exactly what it sounds like, guys. So, spastic lower extremities greater than upper, hips and knees are flexed and adducted with ankles extended, internally rotated, circumduct lower extremities, upper extremities held in a mid to low guard position. Again, you're like, picture does me no good. Let's watch it in a second. Let me just go through all these. So, steppage or neuropathic gait is most often with peripheral nerve disease. These folks cannot feel their feet. Right? So they cannot feel their feet, so it's just like it sounds like they're overemphasizing, and they look like they're going upstairs, but they're not. So think about when you go up a stair, you lift your foot, they're just walking like that because they have loss of sensory function in their foot. Okay? All right, we'll watch that one in a second. Waddling or myopathic gait, just star this one because I'm pretty sure I asked you guys a question on this. We'll go over the review anyways, but proximal limb weakness. I think I asked a question on this because it's the best one. So have you guys seen Reno 9/11 where they do the road test and they're like, and step, bah, step, bah, bah. That's what it looks like. I'm not making fun of anybody. Like if you have this, it sucks. But your hips are kind of doing this and waddling, so I think it's kind of neat looking. So anyway, I get to make the test questions, so that's what it is. So be it. Parkinsonian gait, so it's forward stooping, modest flexion of the hip and knees, arm flex at the elbows, adducted at shoulders. 4 to 6 hertz. Oh, I'm not going to ask you that, but just know that's a slow tremor. So like slow, rhythmic, pill rolling tremor is what they call it. So that 4 to 6 hertz, I don't care. It's in the textbook, but it's not like the spastic choreoathetotic where they're doing this, right? So they're lurched forward. Who do you think has this type of movement? Old people picking on them, right? And then when they go to turn, it's very slow. It's kind of, I don't want to say classic for Parkinsonian shuffle, but apraxia. Do we want to watch videos or just keep going through these? Let's get through all these first, and then we'll watch the videos. I'm thinking about apraxia, finding bilateral frontal lobe disease, maybe accompanied by dementia and continence. Resembles a Parkinsonian gait, stoop posture with short shuffling steps. Different initiation though. Patient is asked to step forward while staring. There's a long pause before that's very specific. So if you see a Parkinsonian gait, keep apraxia in your differential. Choreoathetotic is very, I don't want to say wild looking, but this is a hyperkinetic gait seen with certain types of basal ganglia disorders we'll talk about. But choreoathetosis is like this writhing like movement that is non-predictable and kind of chaotic. And we'll see this in Huntington's disease and some of the other ones we'll talk about a little bit later. So. Cerebellar ataxia, what do you guys think this is going to look like? Unstable, good. Wide, broad-based gait, truncal instability with erect posture, irregular lurching steps in which speed and stride vary and results in a lateral veering and if severe, they fall. So when we talk about the killer crossover, right? So this could be from a cerebellar stroke, but think about somebody out at the bar that drank too much, right? So they're stepping wide, crossing over, they're very unsteady on their feet, okay? So it doesn't mean that everybody you see doing that is drunk. So when I told you guys in the beginning, go out to Target and Walmart, you're like, he's a drunk, he's a drunk. They may have strokes, so be sensitive on that subject. Take booze bag, you need a drink. I had a stroke, a-hole. Just be careful. So, sensory ataxia, so this is going to resemble a cerebellar gait, right? So this person can't feel. So again, they're having trouble with their sensory perception of their feet. God bless you. They can still maintain their balance with their eyes, but they get loss of visual input and can cause some instability. So patient most likely will have a positive Romberg sign. So vestibular ataxia, this one's neat. So sometimes your inner ear stuff, patients tend to fall to the affected side. So again, it could be happening with walking or standing. Physical exam, you can see asymmetric nystagmus, which is that beating of the eyes, hopefully horizontal, because vertical nystagmus, we learn later, is very bad. Normal proprioception and normal strength. So anybody ever have like a killer ear infection as an adult here? No? So I had, anybody do ROTC or am I the only jerk in here? ROTC? What's the camp they made us go to?
Change the name every year.
Yeah, I know.
Now it's a CST.
Whatever that camp was, I woke up one day and I thought I was like poisoned. Like, because everything I was walking, I was like walking in circles, and it turned out that I had a really bad ear infection. So they said, put me on antibiotics, and I was right in like 24 hours. But I remember I was always told, never go to sick call, never be that guy. And I was trying to walk to sick call, and I was like basically crawling. I'm like, help me, medic. They're like, what's wrong with you, dude? I'm like, I don't know. Someone poisoned me last night. They're like, you have an ear infection. I'm like, okay, cool. So I can appreciate that one. Astasia abasia, so this is a psychogenetic gait disorder. So exam shows normal coordination, leg movement while lying or sitting. Yet when they get up to stand and walk around, they've got all sorts of problems. So I want to consider like psych referrals for this one. All right, let's just pause, because I don't know for you guys, it's tough to flip slides and go through gates when you can just watch my homie do it right here. So. I think are they embedded, the YouTube links on your guys' slides or no? In the notes? Okay, good. We'll just watch them real quick after we hear this riveting message from Liberty Bibberty. Yeah. Oh, you're not even
The gait that I'm going to demonstrate now is the hemiparetic gait. This gait, if we were to demonstrate it, we need to be able to show the extension of the leg and internal rotation. So the leg is too long. We have circumduction with the paretic side, but very importantly as well is that the upper extremity is very much involved. And so there's adduction of the shoulder, flexion of the elbow, pronation of the wrist, the thumb is tucked under, and a cortical fist. So this is the position of the hemiparetic gait, with the other side being normal, having normal associated movements. You can actually hear the pattern of the gait as well, as we have circumduction for the paretic side. Again.
All right, that's your hemiparetic. We'll just go through all these and talk about it if you guys have questions. Okay.
My name is Sophie.
Hi, Sasha.
Robert. Ron. And I'm alive thanks to my nurse practitioner.
My nurse practitioner is
They're our friends.
The next gait is a spasmodiplegic gait. In this particular gait, both lower extremities are affected, and the lower extremities are affected more than the upper extremities. So the posture, the position of this particular gait is there's flexion at the hips, flexion at the knees, and the feet or the ankles are extended and internally rotated, and there's also tight adductors, so there's adduction at the knees. So it is a swinging gait with both sides, both lower extremities. You can hear a different pattern in the hemiparetic gait. But this is not all. The upper extremities are also involved. Again, not as much as the hemiparetic gait, but for the upper extremities, the extremity is carried in a low guard or mid guard position, and you don't have the normal associated movements in the upper extremity. So this would be the type of posture, the type of position that one would see for the spastic diplegic.
Did someone say T-Rex? All right, so that's your scissor. Let's keep going. There's only a couple more. So.
The next gait is going to be that of a neuropathic gait in which the distal lower extremity is affected. For this particular gait, the person has the inability to dorsiflex the foot, and so the foot is actually a foot drop, and the person must step high in order to clear the foot. So if I don't step high enough, I'm going to drag the toe of the shoe, and so what happens is the person steps high to be able to clear the foot. As the foot drags, or as the foot drop position.
Thanks, sir. Two more, we're almost there. Bear with me.
This gait is a myopathic gait. With myopathies, usually we have weakness in the pelvic girdle region. And as I walk, if I can't stabilize my pelvis, then what ends up happening is that for the weight-bearing leg, I'm trying to stabilize the hip. And I'm coming off with the other, the pelvis will then dip or drop towards the non-bearing extremity. Now, if I continue in this attitude, I'll fall. In order to compensate for that, I'm going to shift my weight, and I'm going to try to put it over the weight-bearing leg. And so I'm going to actually swing the body towards weight-bearing leg and trying to get hyperlordotic and lock back over the hip that's stabilizing or is actually supporting the weight. So what will this happen is that there will be a waddle as the pelvis will actually drop, come back up, drop on the other side, and go back and forth instead of being nice and perpendicular to where it should be to the leg. So again, this is what it would look like if I'm going to walk. As I take this step, the pelvis will drop, I'll shift this way, and then as I come through, I'll shift this way, the pelvis will drop on the opposite side, and there will be a waddle. I'm in a hyperlordotic position, trying to maintain my balance. So the pelvis drops, shifting to the opposite side.
Thanks, buddy. What are we doing? Is this the same one? I don't want to see the same one.
This gait is a myopathic
No,
gait.
buddy. I want to see that Parkinson's.
Myopathies usually.
Get your Parkinson's out, man. All right, bear with me. This one doesn't come out. That's okay.
Hey, someone's looking.
This gait
Okay.
is the
Last one.
gait that is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture in which he'll be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around.
Statues don't move, buddy.
And then, again, having difficulty starting in the march petit pas.
Okay. Is that helpful at all, or complete waste of time?
A lot better.
Yeah, I've tried to show it and do it up and down. It just doesn't work out. So again, some folks afterwards they were like, they just all look the same to me. Like, I don't know how to do this. Just kind of watch it and try to dissect it. So that hemiperitic gait. So that first one we saw, I think he was using his right side. That's going to be common in your stroke patients, right? Left-sided MCA strokes will affect the right side. So you may see complete hemiparesis there. And then, what else? That waddling one, you'll probably get a question on that one or two. And then, I don't know, try to pick out what's different. Because if I'm attacking that from you guys, try to see what's different from them, then kind of reverse engineer. That Parkinsonian gait, so I think I see those ones coming to the, or what are they coming to see for? For their gait problems, or is it because they fall? They're very unstable, like I am. I don't even know what just happened here. Extremely unstable, they're falling all the time and hitting their heads or breaking hips or breaking bones. So again, one of the things I always consider, I know this is outside, maybe a little bit outside of neuro, but if you're in the ER, not like how or why they fell. Why did they fall in the first place? Are they syncopized? Is it a gait issue? Is it systemic disease? Was it a mechanical fall? I feel much better when someone's like, I tripped because it was icy and slipped forward, as opposed to I was walking along IPAP studying and I just completely syncopize, and you're like, that's probably not good, right? So that's a concern. So just my own 2 cents on that. All right, we'll get into some demyelinating diseases. We're going to talk about MS. We'll get some questions on that one, so pay attention. And then ADEM, or acute disseminated encephalomyelitis, which kind of presents like MS, and we'll talk about the differences between the two. So, MS, everybody hear of MS? Multiple sclerosis, defined as sclerotic plaques in the brain, right? So we'll talk about what it looks like. Just a little bubble. So this is an autoimmune disease, the central nervous system, characterized by inflammation, demyelination, gliosis formation, and then neuronal loss. So you guys can see the prevalence. So you think you'll see this out there on active duty, my active duty folks? Maybe. I've had a couple 1 to 2 cases of it. But unfortunately, like I said, they 40-501, they'll probably get med voided out. So. All right, risk factors, genetic predisposition, vitamin D deficiency, Epstein-Barr virus, which is mononucleosis, exposure after early childhood, and then cigarette smoking. So star this one. I might ask it. So anytime you see something like this, which of the following is not a risk factor, it would be easy to put those up there and then put something wildly ridiculous and be like broken arm, red skin or something, right? So just pay attention to those. These type of slides I hate, so after the first 3, just shut it off. But again, this is per the literature. So sensory loss, optic neuritis, and weakness are pretty much your predominantly findings, followed by paresthesia, diplopia, and then you get into kind of the onesies and twosies. Just know that they're out there and can present like that, so don't shut it off and be like, oh, dementia or bladder problems? Nah, I'm not worried about that. It can be out there and present. It's usually part of the disease process. But those first 3, if a 30 of your patients are coming in with them, that's probably something to pay attention to. Common visual disturbances, so optic neuritis, so periorbital pain, extraocular movements, they have pain. So again, so we talked about a couple things. If we remember, talked about preceptal and or preorbital and orbital cellulitis. Do you guys remember that? So that pain with ocular movements, is that a concerning finding? Yeah, right? So that's why we do that. So if they're not painful, then okay, just document it and move forward. So if they got extraocular movement pain and visual loss, that should start kind of ringing some bells for you. They probably got swelling of that optic nerve or optic neuritis. Double vision, diplopia, internuclear ophthalmoplegia, so they got an impaired adduction of the eye, secondary to lesion, and the ipsilateral medial longitudinal fasciculus. Don't care that you memorize that, but that's kind of causing some of their eye pain. And then a 6th nerve palsy, which, what is the 6th nerve? Cranial nerve? How many people say lateral rectus? The 6th cranial nerve? Okay. Go with your cranial nerves, but you're telling me a little bit better about what the muscle is. Good. All right. Clinical manifestations, limb weakness, loss of strength, fatigue, and gait disturbances. Typically, it's exercise-induced. Upper motor neuron lesion, which we talked upper versus lower, so that's going to be your spasticity. Babinski sign and hyperreflexia, right? So that's loss of inhibition. So we talked about that in the first couple UMass Chris slides where I simplified it for you guys, okay? Facial weakness and then spasticity, just a little bit more information there. So understanding kind of what's going on. So if it's an upper motor neuron disease or pathology, where do we think we're going to find issues? Yeah, spinal cord to CNS, right? So CNS, PNS would have been a better question to ask, but probably the central nervous system. So. All right, sensory symptoms, ataxia, bowel or bladder dysfunction, we talked about a second ago. Depression, fatigue, right? So depression, very common. Fatigability, we talked about. So most common reason for work-related disability in MS. This is definitely, so circle the first one. There's 3 main types. Relapsing, remitting, most common by far. So that's an easy question to ask you guys, but let's understand it too. So not just survive the 2 points. Relapsing, remitting means what? It goes away and comes back, okay? And we'll talk about that in a second. We may not be characterizing these diseases. It's probably neurology, but let's be aware that they're out there. Secondary progressive and then primary progressive. This is kind of the way I think it's easier to think about. So this is your relapsing, remitting, most common. They have an episode, they get better. Comes back, less severe, they get better. Come back, more severe, maybe it's less severe, so it does relapsing, remitting. right? Does that make sense to everybody? It's like a yo-yo. As opposed to your primary and secondary, you guys can see the pattern there. But I would like us to know most common things. So relapsing, remitting, if patients are coming in, right? And we said, what are the main things they're going to come in for? Well, I'm going backwards. Here we go. Sensory loss, optic neuritis, and weakness. And it comes and it goes. Has this ever happened before? Yeah, a couple months ago I had a similar episode, but I got better, so I don't know what's going on. That should kind of ring some bells for you guys, okay? No definitive test, right? So MRI is going to be the most useful. There's a couple tools we can, so there's no marker to pull as of right now. Is there, have they come up with a marker recently? I'm going to say no because the literature says no. But so things are changing, right? So when we talk about medications, there's newer meds out there. I'm just telling you kind of what the literature says for our textbook. So when you're out there, and like a lot of these DMARDs that are out there, great, outstanding. And there's a lot of advancement we're making, so this isn't all-encompassing. But for now, MRI is going to be the most helpful, and we'll talk about spinal tap findings as well. So because when these patients come in and see me in the ER, we're probably getting a full court press, right? So they're probably getting shotgun labs, CT, LP, potentially. So what are we going to find? What do you guys see here? Positive arrow sign? There's gliotic formations. So this is no contrast. What do you guys see? Is it hard to see for y'all? It's hard for me to see. What do we see here with contrast? Bright white. What are these? These are these gliotic formations, which is basically like abnormal protein uptake, scarring, if you will, in the brain. Okay? Should they be there? No. If they're there, are they causing problems? Yes. What type of problems do they present with? Sensory problems, ocular pain, right? Motor function disturbances. So things to think about. Hallmark of the diagnosis, 2 or more episodes of symptoms, 2 or more signs or symptoms longer than 24. I don't think I'm going to ask you guys this. I might give you a patient and I'll give you positive gliotic formation on the MRI. I might show you some white uptake there. And then your CSF, oligoclonal banding. Did we talk about this at all? This is the only time we're going to mention oligoclonal banding in your CSF. So again, if you do a CSF tap, you're probably trying to rule out meningitis or something. If it comes back and it's like oligoclonal bands, right, this could be a pertinent positive that this is MS. Okay, so just something to consider. Treatment, how do we treat it? Treat the current attack, disease modifiers, and then symptomatic therapy. Okay, current attack, what are we going to do? So autoimmune, we say it's an autoimmune disease where our body's attacking our own cells. So let's try to calm that down and stop doing that. So steroids, are there long-term adverse effects or adverse effects to long-term steroid use? Yeah, like Cushing's disease, right? You know, buffalo hump, moon facies, striae, all that good stuff. You guys are in endo? Endo for weeks, right? Yeah. So short burst and taper. So methylprednisolone, 1 gram daily, IV for 3 days, and then oral prednisone. That's pretty high dose. That's a healthy dose for 1 week and then taper. So remember, you guys, you burst that and taper. Don't just give them a huge dose and then say stop. The adrenal glands are going to be upset at you. So. Disease modifiers. These are some of these newer medications. If they end in UMAB, they're usually kind of the newer Humira, or what are some other ones? Tremfya, or some of these risankizumab. Like, though you see commercials for them every day, at least the shows I'm watching. So I'm not going to have you guys remember these. I just want you to know that there's DMARDs out there that can slow this progression down. Okay. This is the aim, like I said, to slow relapses or delay onset, significant ability, but it's not going to stop it or cure the disease, okay? Oh, wait, what did I write down there? Nothing. I didn't write anything important. So. The prognosis, most patients with MS have progressive disability, 15 years to onset. 15 years after onset, only 20% will have no functional limitation. So what does that say? Slow, right? Slow and steady. So slow and steady progressive disease. Favorable prognosis when optic neuritis or sensory symptoms at onset, because that's usually good that we catch it sooner than later and try to slow that down. Less than 2 relapses in the first year, and then minimal impairment after 5 years, usually an indicator of how slow or fast it's going to progress. What do we hear? Okay, so in patients with their first demyelinating event, the MRI brain provides prognostic information. So This is good. I'm gonna say this is kind of good to know, but good for kind of neuro. So we need to be able to figure this, find it out, and then refer them to neuro, and they can give them kind of the prognosis, if you will. But this is just some good information. With 3 or more typical T2 weighted lesions, the risk of developing MS after 20 years is pretty high. Normal brain, it's pretty low. It's still not 100% gone. So just because you MRI someone and they're normal and they're having these symptoms, you can't really definitively say to them, like, you do not have or will not get MS, right? So just be careful with that, I'd say. All right, so remember MS, because we'll get some questions, right? So relapsing, remitting, remember the first couple signs and symptoms of it. Remember how you treat an acute flare, which is steroids. I think there's probably like 5 or 6 steroid questions on there. So if there's med questions, steroids is usually a good answer. I'm not trying to teach you the test, but you know, just choose steroids, unless I tell you otherwise. All right, ADEM, acute disseminated encephalomyelitis. So this is a monophasic illness leading to CNS demyelination. So this is the other one I was talking about. So hard to distinguish from MS, especially due to the fact that the major presentation is optic neuritis. So just keep it in your differential. If you're dealing with MS and you're concerned about MS, keep ADEM or ADEM in there as well. So lesions are different. So the real big change to this one is going to be your MRI findings, right, and your CS findings or your CSF. But don't get wrapped around the axle. So hallmark is the presence of widely scattered small foci of periventricular, I should say, inflammation, the demyelination, as opposed to larger confluent demyelinated lesions. Whatever, man. It presents the same. So smaller lesions versus larger lesions, okay? CSF, so oligoclonal bands rarely seen in this one, so more prevalent with MS, so I'd say that's a differentiator. And then the prognosis is typically complete. So recovery, typically complete. IV steroids often shorten the course and lessen the severity. So that's another differentiator between MS. This one you can get rid of. All right, motor neuron disease, and then we'll break because we've been at it for a little bit. All right, we're making progress. So ALS and polio. Polio, unfortunately, is making a little bit of a research. ALS, most common progressive motor neuron disease. So if I ask you what's the most common progressive neuron disease, is a good one to choose. So underline that first bullet. Anybody know anybody with ALS personally? Anybody else? So a couple folks. I'm seeing usually 2 or 3 folks. How about famous folks with ALS? Don't say Lou Gehrig. You don't know him. Stephen Hawkins? You don't know him. Yeah. Parkinson's disease. Yeah. Steve Gleason. Anybody remember Steve? He was a Saints player. So like Major McMahon was saying about, I don't know if it's YouTube you mentioned, but sometimes a lot with the advancements in technology, a lot of folks are like kind of projecting or documenting their trip through disease, which is, that's pretty sad, but it's certainly helpful when you guys are trying to memorize it to put a face to the disease process. So Steve Gleason was a NFL player for the Saints. So you got to think pinnacle of like, you know, physical exceptionalism. I guess that's a good word to say. And then contracts ALS, and then he documents his whole trip through it, and just watching him kind of wither away. And I think someone double check. I think he passed away recently. Did he? Like, yeah. Like, anybody want to look it up? No, I'm just curious now. But I thought one of the saddest things was towards the end of his progression. Like, he had a young family too. That kind of makes it a little bit harder. But he was at some church ceremony, and it was on video. And the pastor, whoever, was like, yeah, you just got to believe you're healed. You just got to believe it in your mind. Think that you're healed. And he was like so dejected, and it was hard to see such this strong guy who was playing a professional sport at the height of his career, was now in a wheelchair, and was like, oh, I got to believe it? Oh, if that's all I have to do. And he stood up and tried to run and just fell flat on his face. And he like kept doing it. And he was like, but I'm believing, because his mind was completely sharp. Like, he was all there, but his body was just quitting. So it's pretty powerful stuff. I remember watching it, and I was like, man, that's terrible, but powerful guy to go through it and share it with the world. So anyways, this is the most common progressive motor neuron disease, motor neuron degeneration of upper and lower, amyotrophy, so no muscle nourishment, follows by And then it's in the name, so annulolateral sclerosis, it tells you what it's doing. So that lateral sclerosis is loss of fibers in lateral columns and resulting fibulary gliosis, in part a particular firmness, or it gets hard, right? So mind is still there. So mind is still there, the body quits. So here's some examples for you. Systems, asymmetrical weakness, loss of bowel or bladder, sensory bowel and bladder cognition is intact, my bad, until later. Simultaneous upper and lower motor neuron involvement with progressive weakness. So this is a tough one. Median survival 3 to 5 years, usually from respiratory disease, respiratory paralysis, that diaphragm usually quits out, or a lot of times they'll get like an aspiration pneumonia secondary from breathing issues. So you can see the incidence there, male is greater than female, okay, and then it can be hereditary too. So. Treatment, no cure. Fortunately, we don't have one on this one. We're making some strides in this. There's some medications there, right? So I don't want you to memorize these. We can look them up if we need to, but usually neurology is going to be managing this patient. So, all right. Polio, so poliovirus, enterovirus, fecal to oral route, so 3 wild polio serotypes. Where do you guys think we're seeing this? Central Asia? Yeah, so overseas. Did we go over there? Yep, so unfortunately we might see it. So, actually, did anybody remember the iron lung guy? He died, finally. Yeah, so that dude lived forever, man, and he was in Texas. My goal was to try to bring a neuro class to go see him, but it never worked out. He died too quick. So. Anyways, he was in the iron lung for quite some time. He contracted polio as a kid. So viral infection, what does it do? Destroys the anterior horn cells in the spinal cord. You get weakness or paralysis. Respiratory muscles may be affected, and that was that gentleman who was in that iron lung. So just something to consider if you guys are traveling out and about. So. All right, let's break, and then we'll come back and finish up. I always have an odd sense of can't always say. Is still alive. Is he really? So did I thought so too.
Or he's gonna say, I'm a previous felon.
Jake or somebody boarded and
Sounds like it does that as long as
So yeah. Aggressive.
You're collecting pension for different disability. Dermatology, occupational therapy, family med.
What would be soul crushing? What is being soul crushing?
What would it be? Anything, I mean, you'll see like soul occupational. Maybe 2 days a week. ER, I'm lucky with ER. It's more with a whole and then a whole. Also, you play sports league? Like go It's maintain skills as well. You get to excited things. No, I'm not back. I have to not get my access done.
I was talking about my head like racquetball.
Take a step. So you don't have to. You don't have to. Be very fine. Very fine. I would say baseball, when you look at life, I would throw the ball in there. What if you don't get the score? What if you get beat? That's a free hit. But I'm down. Nobody can shoot back there. Nobody gave him space. Nobody gave us that defense. No, they get a lot of space.
I don't know if that answers your question. It's hard to think about, hey, what do I do after that?
I know. All right, we ready? You guys want to finish up? All right, Steve Gleason is still alive. So clearly I tried to put him in the grave. He is still alive. So diagnosed with ALS in 2011. As of last year, he's still alive. So kind of defying odds. I couldn't find any videos of him recently. Wanted to make that correction. I apologize, Mr. Gleason. All right, the next part we're going to get into is cord disorders. I have a lot to say about these, but I'll try to make it as easy as possible. Because when you first look at the next part, this last half of this lecture, it can kind of be a little bit intimidating. Feedback I got through some of the other classes were like, you're just assuming that we know this anatomy. So I am a little bit, but if I go through these and lose you, you got to, one, let me know. And two, you got to spend a little bit of time on this to understand some of it, okay? So this is one that I can't kind of clip you guys out of without knowing your anatomy or what's being affected. Remember, always go back to that. So think about it from the perspective is if I have a patient that's boarded and collared and presenting with these symptoms, what is being affected? Like what part of their spinal cord potentially could be affected? You're not going to hang your life on it and say, no, we don't need any examination or CT, or we don't need this because I know I learned this. It's not how this works. But unfortunately, we have to look at it in like a myopic construct to understand it. So that's my disclaimer as we move forward here. So, all right, cord disorders usually from a severe trauma. We already know that, right? So that's why we board and collar folks early for any type of trauma, or we try to at least maintain C-spine. That's kind of the first thing we teach some of our medics. So, okay. Generally speaking, above C5, respiratory insufficiency likely to result due to weakness of the diaphragm. Abdominal reflexes are loss of lesions at T6, bladder and bowel dysfunction with lesions above the sacral level. So some of the things, this is just kind of like overarching shots across the bow. There's some landmarks, some things to consider. So when you guys hear bowel or bladder dysfunction or loss, what do you think about typically? Cataclynous syndrome, that's a big one, right? So could it be a spinal abscess? Sure, I've seen a bunch of those on my drug addicts. But that's why when you get to ortho and back pain, you guys are always doing your straight leg raise. You're always asking saddle anesthesia, loss of bowel or bladder. Actually, the first symptom of cataclynous is going to be urinary retention. So first they can't pee, and then they're going to start peeing all over themselves. So, interestingly enough, I've had a couple of those where I was like, it's kind of iffy. One of the things that my neurosurgeons always want me to do now, I don't know if you guys talk about this in either surgery and or ortho, is like a post-void residual bladder scan. So it just makes sense. But I usually will do an exam. Like I had a guy Sunday, again, another 60-year-old guy, lower extremity, lost sensation, motor functions, peeing on himself. He says he was peeing on himself. He's wearing a diaper. I'm not going to make him prove it. Physical exam, diminished reflexes. He's got some atrophy. Radiograph plain film or CT showed pretty moderate to severe foraminal stenosis at the level that I'd be concerned about. It also showed some sort of lesion there, which I wasn't sure what that was. But I called neurosurgery, gave him a bunch of pain meds, wasn't controlling him. He's an easy admit for intractable pain, but neurosurgery was like, do a bladder scan, post-void residual, and it was 0. And he's like, yeah, it's probably not cataclynous syndrome. And I'm like, oh, all right, cool. So have him pee, have him empty his bladder, and then scan it. And if he's not holding fluids, they were saying that's kind of like a proof positive for them that it's not cataclynous. What else can we do for neurological assessment in this patient? What else do you think I did? Touch, did I touch him? Sharp dull, I think I did the sharp dull. Yeah, of course, right? Sharp dull, DRE, you said that, 100%. Do I DRE all my patients with back pain? DRE all my patients with back pain peeing on themselves. Yeah, because I know the neurosurgeon is going to ask, is he neurologically intact? Yeah, he's got good sphincter toe. So, all right.
There's only 2 contraindications to a DRE.
Here we go.
Either the patient doesn't have a rectum anymore, or you don't have a finger anymore. That's a classic ER-ism, just because people are very hesitant to do it sometimes.
All over myself.
You will hear that in ER at least
Oh my
once.
God, that was embarrassing. More embarrassing than me spinning all over myself was I just gave myself a shower. Anybody see that? Could I have played that off like it was nothing? My computer's going to start smoking in a second. But anyways, all right. So yes, he got a DRE, he got admitted, and I was actually able to get an MRI of him pretty quickly, which showed some concerning findings. So he was probably going to surgery, what's today? Wednesday? He might have had surgery Monday or Tuesday. The surgeon said he wasn't too excited to come in to decompress emergently, but he's like, all roads lead to surgery, so we're going to do it probably Monday or Tuesday. I'm like, roger that, sir. You're the man. All right, do you guys remember this? It might not be in your, if you guys didn't believe me, here it is. Like, this isn't sweat, this is water. So, is this in your slide deck? No? All right, this was a slide that we had the other day, and I need you guys to understand the next 20 slides, we got to understand this. So I told you guys either last week or whenever we met that you gotta kind of memorize some things for me. So corticospinal tract, we need to know is voluntary motor activity on the ipsilateral side, okay? Spinal thalamic tract is responsible for pain, temperature, light, crude touch, and pressure for the contralateral side. And then your posterior dorsal column, spine touch, 2-point discrimination, and proprioception on the same side. You guys remember that? Does that look familiar? If you understand that, then the next 20 slides are a piece of cake. Because this is all we're doing is talking about if we cut out a certain part, if I cut out the corticospinal tract at a certain level, what will my patient present like? Okay, and I'm going to tell you from experience, like so the slides are drawn to show you. I'm just going to speed through this. That we're cutting out, so we're having a lesion. Maybe it's a mass, maybe it's a tumor, maybe it's trauma. So we have a lesion on the right dorsal column at L1, produces what impairment? That's a question, you guys. So we're knocking this out. L1, this is L1, lumbar, first one, right? We're knocking this out. So we need to go back to that other slide and figure out what those dorsal columns are for and what they do and if it's the ipsilateral or contralateral side. Does that make sense to everybody? Have I lost anybody yet? You guys are way smarter than the other class. All right, so this is all it's saying. And again, you're like, why is this so fancy? I inherited it fancy and I kind of liked it. So the guy I took this from was like, here, we cut this area here. And then the students were like, whoa, why'd you cut it? What are you doing? Are you doing surgery? I'm like, no, I'm not doing anything. Like, let's just say it's a stop sign and it's sliced through that from an accident. I don't care what it is. Maybe it's a mass or a tumor growing there. Use your imagination. Whatever it is that's knocked out. What type of symptoms are they going to have? You guys will already know. Damage to the right dorsal column at L1 causes the absence of vibration, position extension of the right leg, and only, just FYSA, only the fasciculus gracilis exits below T6. I don't really care that you know that. But. So, does that make sense to you guys? This is summarizing it. Right dorsal column, so let's flip back and go back to that first slide that I told you. Dorsal column is responsible for what? At the bottom, posterior of the dorsal column, fine touch, 2-point discrim, and proprioception on the same or opposite side. Same, ipsilateral side. So if we knock it out or we have a lesion there at L1, we got to understand where that is in the anatomy, spinal cord anatomy. What symptoms am I going to have? L1 and below, we're going to have symptoms of that leg right here. This is kind of useful for me. This puts it all together. So this is, again, just showing us knocking out that dorsal column in red. If the scalpel's bothering you, take it away. But this is just showing if somehow you can magnify this and take this little area out, these are your symptoms your patient are going to have. Is that fair? Does that make sense? Is anybody completely lost or hate these slides? If you hate them, let me know, or let my brother or my Major McMahon know, because I don't know. Sometimes I get feedback that like these slides are nuts. Like I don't know why you put them up there. So we can fast forward through all this, and again, we don't have to slow roll it. I skip a bunch. So central cord syndrome, right? So lateral spinal thalamic tract. Right, so lesion in the anterior and white commissures or central cord syndrome at C5, C6 produce what impairment? So lateral spinal thalamic, go back to that first one. I don't want to flip back because I'll make people dizzy. What did we say lateral spinal thalamic was? Temperature. Okay, good. So we take out those small little areas or sometimes those lateral spinal thalamic tract. What's going to happen? Impaired pain and temperature sensation, C5, 6 dermatomes bilaterally. Okay, why is it bilaterally? We took them both out. If I took one out, it would be corresponding difference. The reason I put this one up here is because it's always asked on pants questions, and it's a cape-like distribution. How many of y'all wear capes? When was the last time you put on a cape? Never, right? But they'll always say in a cape-like distribution. If they're talking about that, loss of pain and temperature on their arms, like if you were wearing a cape, if you wore capes, think about central cord syndrome. Is that fair? Okay. I think I highlighted this one because I had a question on it the other day. So complete transection. So now I'm knocking out all three of the ones we just talked about. Brown-Séquard syndrome, absolutely. So now you have to go back to that first slide I told you because two of them are going to be on the same side. One is going to be on the contralateral side. You have to memorize that and know that you're now going to have symptoms on both sides. And you guys, as students, have to figure out what is that going to present like, okay? So complete transection of the right side. So again, I don't care how you get there. Surgeon slips and cuts this for some reason. Person's in a car crash and a stop sign, piece of metal, cuts through that. I don't care. They're laying on your bed and they present with what type of symptoms or impairment? What do you guys think? Good, it's right there. The scalpel's over it, which kind of sucks. So ipsilateral dorsicolumn loss. Your lateral cortical spinal tract lesion, ipsilateral symptoms, and the spinal thalamic contralateral. So pain and temperature on the opposite side, the other ones are going to be on the same side. Okay? Do I have a better picture of this? There we go. That'll work. Does this make sense to you guys? It's a lot, I get it. If you go back to that first slide that tells you what we're looking for, what symptoms, and how it presents, it'll save a lot of ass pain on this. Because if you're looking at just this, this can be kind of cumbersome. I get it. I don't know if there's a better way to show it. I could probably UMass Amherst this one as well, where I'm just like, you cut it, and it's bad, right? But again, so your patient's there, your patient's laying on the spine board, right? And they've got a collar on, and you see maybe signs of trauma in their lower spine, specifically at L1, their lower leg, and they're telling you they can't move their right leg, but they can move their left leg, but they can't feel certain things. Like, this is where I want you guys to put this into clinical. Why is this clinically relevant? Because he's totally not moving his right leg, but he's like, I can move this one, but I'm losing what? Right? What am I losing here? Pain and temperature response. Like, how do you find that out? Pain, how do we test pain? Sharp, dull. You may not be able to test temperature. You're not going to take like a cautery knife and be like, how does this feel? Oh God, I think this is a problem. But pain's in our wheelhouse. I've lost sharp, dull, but I can move this. That wants you, maybe you can think about something like this, okay? Fair? Fair so far? All right, you guys are way cooler. This is just putting it all together. There's a question on there on Brown-Séquard syndrome on your exam. So just take a look at Brown-Séquard and how it presents. All right, complete transection at L1. This one should just kind of make sense. So if I completely cut the cord at L1, that stop sign just went completely through their lower back, right? So from L1 down, they're going to have what? Oops, I didn't do that. Paralysis, right? So they're not going to feel anything or move anything. Does that make sense? Why from the legs down? Well, because L1 down, what does that innervate? It's cut. But what about L2, L3, L4? They're not getting anything. It's game over. They're not feeling anything. So you guys can read that if you want to, the book learning explanation, but both legs, paraplegia, right? Dunsky. All right, what else? Transverse cord lesion. So now, what we just talked about? Complete transection. Oh, the posterior anterior transection. Do I give you guys questions about this? Again, just pay attention. If I don't give you guys a question about this one, so I'm not sure why it's there. But complete transection of the dorsal columns bilaterally, or posterior cord syndrome. Go back to the beginning. What is our dorsal columns responsible for? What are our dorsal columns responsible for? Go back and look. I'm not going to do it, right? So position sense, vibratory sense. How do we test that stuff? How do we test position and vibratory sense? Okay, position, movement. What else can we do with position? Right, up and down, right? That's always good. Okay. So damage to the dorsal column, specifically the fasciculus gracilis or cuneatus, bilaterally causes the absence of vibration, position sense, bilaterally from the neck down. So whatever's causing it, if it's a mass, a transection, your patient's going to present something like this. Okay, does that make sense? Again, I think these summative slides probably are easier than how we're getting there. But again, if this is knocked out for some reason, this is going to be how your patient presents. How do we figure that out? You guys are testing this. You may not have a brush, right? You may not have that cool brush. But that's why we're doing our sharp dull. That's why we're doing our proprioception. That's why we do these bedside exams. That's why I'm trying to make this kind of more relevant for you guys. Right? So we talked about posterior cord, anterior cord syndrome. So let's just exercise all the way up to here. Just kidding. So anterior cord syndrome, now you guys can see my shaded area over here. I apologize to this side of the class. You know what? I'm not going to apologize. I'm just going to go over here. Screw you guys. No, I'm just kidding. So now we talked about posterior cutting this. Now we're cutting everything else for whatever reason. Mass, tumor, I don't care. What is that going to look like and how is your patient going to present? Okay? So we have lateral cortical spinal tract, ipsilateral motor symptoms, right? And then lateral spinal thalamic tract, contralateral loss of pain and temperature in your patient. Okay, then you guys can see their common causes on the side: anterior spinal artery infarct, trauma, or MS, which is one we talked about. So that would be some pretty severe MS symptoms. Is that okay for you guys? If you're having trouble getting there and those transition slides don't do it for you, just go to here and again, backwards engineer this thing. what am I looking at? Start with the top right. The shaded part is what we're knocking out. So this part is gone right here. If I take this away, what level did we say? Is it on here? If I take it's way up in his head, so in his neck area. So if I take this away in his cervical spine, what is this guy or gal going to present like? That's really what I want you guys to take away from that. Does that make sense? All right. What's that? Yeah, that's a bad one. So, yeah, it's a different way to put it, but it's a bad one. So, all right, cord compression. Some different causes of cord compressions: tumor masses, right? So neoplastic tumors, 15% of primary CNS tumors. Epidural abscess is hematoma granuloma. So those epidural abscess, think about in your IV drug users. Herniated discs. Anybody heard of those or have those? Yeah. So think about your nucleus pulposus and your annulofibrosis. So I always tell patients they don't know that. Just sell them a jelly donut. So it's got a hard outside, squishy inside. You squish the jelly out, it hits a nerve, right? So that can cause some cord compression. You tell a 400-pound San Antonian nucleus pulposus and annulofibrosis, they look at you like you're crazy. You tell them a jelly donut, and they're like, where? Where? Say less. So there's a lot of food kind of comparisons that are out there. So spondylolysis, right? So vertebral OA or osteoarthritis, which is common. You kind of see that in our older folks. Vertebral compression fractures, foreign body, bullet, sharp shrapnel. And then also findings are often, you see back pain, bladder disturbances, sensory problems, or paresthesia of the leg. Okay, so this isn't all-encompassing, but just some things to consider. So things we got to make sure that aren't going on. So, all right, two groups of tumors, intermedullary and extramedullary. You can see there highlighted. Extramedullary are largely more common. Okay, 90%. Those are going to be most commonly related to neurofibromas and meningiomas. Don't care if you memorize the part of it, but they're way extramedullary and be more common. Okay? Clinical findings, neurodeficit caused by direct compression, arterial venous insufficiency, invasive infiltration if it's an intramedullary lesion, so if it's actually within the parenchyma itself. So, what do they present like, right? So this is kind of that cauda stuff we talked about. So radicular, localized, diffuse pain, heaviness, weakness, stiffness, atrophy, or one or more limbs. Localized spinal tenderness, anterior nerve root involvement, or posterior nerve root involvement, and then you can get transverse lesion changes as well. So how do we find all this out? Signs and symptoms. What do we do? Ask our patient, listen to our patient, physical exam, right? So we talked about when do we not do a DRE, when do we not do a physical exam? That's another one. Never. You should always do a physical exam. Minimal, right? Always touch your patient, always do a physical exam, don't assume anything. So, like I always get kind of fired up, especially if you have like a trauma patient that's boarded and collared and they come in. Like you gotta expose that patient, man. You gotta look at everything because you're gonna miss 100% of the stuff that you don't see. So, all right, I digress. Soapbox. CSF analysis, anthrochromatic, what is that? It's blood, right? So blood in the CSF. Technically, anthrochromatic means like yellowing, but it's going to come in as blood in the CSF, right? Is that good or bad? That's bad, right? So we talked about our nervous system in the beginning, I don't know, 4 hours ago when we started this journey. Yes, nervous system is very vascular, but the brain, CSF, does not like blood there. It's caustic, so. You're going to get greatly elevated protein, normal elevated WCs, depending on what you're looking for. Normal or depressed glucose elevation. This Quicken Stat test. Anybody want to take a swing at this one? Have you guys heard this one? I think it's in my notes. Let me make sure I don't make a fool out of myself. Here we go. I'm going to read this, and I've never done this. If you've done it, please speak in. So this is a German physician, Dr. Quickenstad, from 1876. Okay? This is a test for an obstruction in the spinal cord in which the jugular veins on each side of the neck are compressed alternately, and then the pressure of the spinal fluid is measured by a manometry, collected via lumbar punch. What? So I've never done that. I bring it up. I'm not going to ask you a question on it. I just bring it up because it's in the literature. So I can't imagine if you're seeing somebody that's doing this, they're probably very old. But God bless him. Like, we're gonna do the quick and stand. I knew Dr. Quick and stand. Like, cool, man. Yeah. I'm gonna choke you out while I'm I'm gonna give you like half like of a submission move, and then I'm gonna let go and see if it changes the pressure CSF. So it's out there in the literature. That's why I bring it up. So examination, evaluation. Gotta look at your patient. Distinguish between intramedullary, extramedullary, right? So inside the parenchyma or outside. So is it in the brain or outside the brain tissue? And then treatment, right? So extradural compression, analgesics, pain meds, IV steroids, surgical decompression is usually going to be what we're doing. But really our big thing is steroids or not. So a lot of our nervous tissue, we don't want it swelling, so steroids can help with that as well. So prognosis depends on the severity, how quick we find it, and how quick we get them to definitive treatment. So, all right? What do y'all think? 11:21. We could. Nah, we got tomorrow. What are we doing, man? What am I doing? Let's go. We'll be done and we'll meet tomorrow. Because you guys have class till 5 today, right? 6, 7. What'd you say? Here's like my kid, man. My daughter, I still don't understand.